Where should I start? It's such a pleasure to introduce a very special speaker and guest, Dr. Garima Sharma. She is the Director of Preventive Cardiology, Women's Cardiovascular Health, and Director of Cardio OB at Innova Health System, and also the Martha Shah Indoor Chair in Cardiovascular Health. Now, I've known Garima for almost now 6 years, and I would say one of the very few people that I admire who have this rare quality of taking the science and building a thriving clinical program, community program, a mentorship program, and also taking it beyond where I would say just beyond your system and others with societies. She has been a group member of almost 8 ACC AHA guidelines on cardiovascular disease in women. She chaired the AHA scientific statement on status of maternal cardiovascular health, vice chair of AHA policy statement, and beyond that, she has also been the ACC governor for Maryland for 3 years, which she just completed her tenure. And if things were left, she's also the deputy editor of JACC Advances, and an amazing collaborator with us, mentoring, partnering, and a lot of our team members. I have learned so much, and I'm so excited to hear how you have built the program and where the whole space of cardiovascular health, especially for women, should be headed. Thank you, Garima, for coming.
Thank you so much, Dr. Nasir. You've been such an amazing friend and collaborator. And thank you to Dr. Zogby. You're an amazing role model and a leader. People aspire to be like you. And if I can get, like maybe quarter of what you've achieved, I would consider myself very successful. And Dr. Nasir's team, several of you are here. I've had the pleasure of collaborating with you. And you will see glimpses of that in my talk. Today, and I think that there are certain people that I think God puts you in their way so that you become better and your path becomes better. And I consider Dr. Nasir as one of those people. I'm very fortunate to know him because he's helped shape a lot of the ways I practice and I teach. So thank you. This is very wonderful and humbling to be here. So. I'm going to start about, can you all see it? Yeah, okay, wonderful. I'm going to start by acknowledging that, cardiovascular disease in women has gained a lot of momentum and recognition and understanding, but we're not quite there yet. And I'm hoping to present my perspective on what I think are top 10 important things that maybe people can get out of this and operationalize within their own practices, within their own learning systems, within their own mentoring systems, so that we can all be change agents to advance the care of women and build equitable programs so we're caring for them just as much and just as well as men. My 3 objectives are to focus on sex-specific risk factors associated with cardiovascular disease in addition to traditional risk factors. I will focus on the important updates in screening and management of cardiovascular disease and along the transition in women, focusing on critical time windows where I think this transition becomes particularly difficult and particularly challenging, and how we can really focus on transition points in a woman's life course, so giving a life course perspective, and then talk a little bit about what I've been doing in my health system for the past 2.5 years, focusing on implementing certain care pathways that allow clinicians to care for their patients a little bit better. We were talking a little bit about it over dinner yesterday. So let's start with recognizing the problem. I think we can't do anything about the problem unless we actually recognize where we are. Cardiovascular disease is the largest killer of women, and it continues to be a big burden of morbidity and mortality in women. This is the Lancet Commission that came out in 2024 for the first time, actually put into perspective globally what a challenge this is. But I will tell you that even these data that are pretty staggering and kind of depressing are still underestimation, because we do not collect sex-specific data in many, many parts of the world. And I still think that this is understudied, under-recognized, underreported, undertreated, and we all know that women continue to be underrepresented in clinical trials, whether you look at it from structural clinical trials, interventional clinical trials, electrophysiology clinical trials, or even some of our GLP-1 clinical trials. Achieving 50% participation of women has been a tough spot for us, despite all efforts. And so this continues to be a problem and a challenge for all of us. What are the trends in mortality in women in the US? And the American Heart Association releases these heart disease and stroke statistics each year to kind of put into forward the center. What's the problem? What's the problem with men? What's the problem with women? And intersectionality, age and sex and gender, and as well as cardiovascular risk factors. And what we have recognized, as you can see, the blue and the red graph, the red women are in red, or females are in red. There has been a disparity for a really, really, really long time, where women were dying more than men for almost like 2 decades. And this is because traditionally our structures of care, our systems of care were focused on providing earlier recognition and better treatment to men, and under recognition of sex-specific problems or sex-specific presentation, how women may present differently than men. Our post-MI care, our door-to-balloon time, our uptake in DAPT, dual antiplatelet therapy, our referral for cardiac rehabilitation, our referral for cardiovascular surgery. All of these have really focused on care optimization for men and not for women. As a result, women's care really lagged behind. And in fact, our own understanding of how women may be presenting, or what are some of the sex-predicted risk factors associated with women, has not been that good. And this is a concerning trend. And as you can see, it drops down to kind of better levels in 2010 because of a lot of the work that Dr. Zogby, his colleagues, have been doing in terms of ACC, AHA guidelines, how to better care for patients, how do we translate those guidelines into clinical practice. And in the recent 10, 15 years, those trends are worsening again. These are because inequities in care and increase in obesity and an aging population, and these are not good trends. And particularly if you actually do a slicing of this information based on age stratification, the women that are 35 to 54 years of age actually have shown a higher increase in cardiovascular disease morbidity and mortality, almost overtaking cancer-related deaths. So that's a problem. However, awareness of cardiovascular disease as a leading cause of death in women is actually decreasing. So this is the problem. Not only is the cardiovascular death increasing, but our recognition and the population level recognition. This is data from the American Heart Association survey that comes out every 10 years to look at where people are in their understanding. And women were asked, what is the single biggest killer? And they, overwhelmingly answered cancer. And so this is a problem, and it's kind of staring at us in the face. And if you actually look at it, this decline in awareness from 65% to 44% is more pronounced in younger women, 25 to 34 years of age, women of color, and in women with hypertension. So if people don't know their risks and they don't recognize their risk, how are they going to better seek care? So not only are we dealing with systems of care issues where there's clinician-facing issues, we're also dealing with population-level issues where patients are not aware. Decreasing level of awareness can be because of social media impact. There's a lot on breast cancer. There's recognition that breast cancer is an important cause of morbidity, but there is also a little bit of under-recognition that cardiac disease actually is a single killer. There is underestimation by patients and clinicians. We do know that women present differently in acute settings, but also in chronic settings. They can be insidious. There's limited representation in research, and we can talk a little bit about that. Caregiving responsibilities, lack of self-prioritizing. They're focused on their children, they're focused on their husbands, they're focused on their extended family, and actually deny preventive care, and also a decrease in advocacy. With that in mind, the American Heart Association actually launched this longitudinal registry, which is called Research Goes Red, and I'll talk a little bit about what they've been focused on doing, but it's really an online research platform where women who can actually become a part of this longitudinal study. It's an open source longitudinal dynamic registry that conducts different research studies, mostly focused on awareness, recognition, bias, kind of care, patient practices. And it's an ongoing registry. Right now, there's over 50,000 women in this registry. It's an open building registry, and they kind of focus on awareness questions, experiences questions. How did you experience COVID pandemic? How did you experience patient bias in your reproductive health? Those kind of questions to kind of understand where the gaps in treatment are. And I think the first couple of studies, and you may be able to look this up, were focused on perimenopausal weight gain in women and how that translates into worsening cardiovascular risk factors. And so there's a lot going on in this, and we'll be discussing some of the results of what we did with this AHA-RGR registry. So focusing on sex-specific risk factors across the life course, this is Andrew Nguyen. He's a wonderful first-year fellow now, and he drew this with us when he was a resident at ANOVA, that focuses on really looking at a life course perspective. So we recognize there are traditional risk factors: hypertension, diabetes, obesity, dyslipidemia. But there are certain sex-specific risk factors across the life course that increase the risk. There's a differential risk in women, which is under-recognized and undertreated. And this is across the life course, so different stages, during young adulthood, during the peripartum pregnancy timeframe, as well as middle age. Most of my research has focused on adverse pregnancy outcomes. These are a constellation of placental syndromes that increase the risk of cardiovascular morbidity and mortality long-term. They are all because of placental pathologies. We know that preeclampsia has an independent risk, preterm birth, gestational diabetes, placental abruption. These are important risk factors that multiple longitudinal prospective studies have shown that there is an elevated risk, even after controlling for traditional risk factors. So especially in case of preeclampsia, there's an independent risk associated with heart disease after controlling for chronic hypertension and after controlling for cardiovascular risk factors. So there's something that changes in the vascular biology of the milieu of patients that get preeclampsia. We haven't discovered what exactly that is, but that increases the risk of HFpEF, increases the risk of early premature coronary atherosclerosis, and increases the risk of cardiovascular disease morbidity. And recognition of this is extremely important, which is why a reproductive and contraceptive history that is embedded in your EMR to make sure that clinicians across the health system are implementing a strategy for recognition. Because if you don't ask, you are not going to know unless the women actually tell you. And this is a contraceptive history that is as a part of our clinical notes that we have actually used a dot phrase so that we can really make sure that everyone is asking this. And because we're asking this, we can actually identify people who've had these problems and then attach them to preventive care. So we're catching them at the point of care, and that's fine. We can't send this survey to them at home. But when they're seeing their primary care doctor, they're seeing their cardiovascular clinician, asking this is important. So what are we asking? We're asking whether or not you've had an APO, your age of menarche, your age of menopause. Is it premature? Was it surgical? Was it non-surgical? Did you have primary ovarian failure? What is your parity? How many children did you have? What kind of postpartum health did you have? Did you breastfeed? Did you not breastfeed? Did you have postpartum depression? Are you on hormone replacement therapy? Why are you not on hormone replacement therapy? Did you undergo IVF? Was it surgical? What kind of IVF did you undergo in certain reproductive age women that we see in our clinic? And then asking vasomotor symptoms in patients who are perimenopausal, because we know and we recognize that vasomotor symptoms often are early presentation signs of cardiometabolic disarrangement, and we know that vasomotor signs and symptoms are associated with worsening cardiovascular morbidity and mortality in our menopausal transition patients. So asking this is an important thing because sometimes it can provide a lens to us as to better recognition in addition to traditional risk factors. So I talked about research goes red. I talked about the awareness problem. I talked about a little bit about sex-specific risk factors. But this is actually one of the reproductive experiences surveys from Research Goes Red that we had the ability to look at the data and publish. And here, both postmenopausal women or perimenopausal, postmenopausal women and recently pregnant women were asked. National survey, over about 6,000 patients were asked what is going on with the kind of questions you get asked in clinical care. Are they being evaluated? And the answer is not very good. In the middle, you can see the association between APOs and cardiovascular risk. When specifically asked, did your doctor talk to you about this, or did your clinician talk to you about this? The answers are not there. About 59% of the participants noted that they were not educated about this by their clinicians. And 37% reported that they were not assessed during pregnancy. So these are missed opportunities. You know, I think recognition of this early on is extremely important. This is the status of what is happening in the U.S. You know, it doesn't pertain to any particular region. These are patients that are from all over the U.S. And these kind of surveys are important because it helps give us some guidance of what are some gap knowledges or awareness knowledges that we may be able to eliminate. Okay, what is the state of cardiovascular health? So for those, you know, y'all know this a lot because Dr. Nasir is here, but for those who are not, you know, from the cardiovascular prevention realm, the American Heart Association recently updated its focus from Life's Essentials, Life Simple 7 to Essential 8. This is the construct of what constitutes good health. And really focusing on this in every patient encounter is very simple and easy to do. You know, really, this is something that we preach a lot, knowing your numbers. Are you smoking or not? What's your blood pressure? What's your level of cholesterol? What's your current weight? What's your blood glucose stratification? Where are you there? Are you active? 150 minutes of moderate intensity, 75 minutes of high intensity a week in most individuals. What kind of diet are you eating? Is it healthy in foods and grains and green leafy vegetables? And how much balance of fruits and vegetables are you getting? And sleep health. And so this is a window of how your patients are doing. And the answer actually is not very good because this is data from the NHANES that was published along with the presidential advisory that came out in 2022 that is looking at optimal cardiovascular health. So the green means it's good, higher the numbers, better the scores. It scored from 0 to 100, 100 meaning you're fantastic. But the sad part is most of the US population is actually very bad. And it's intermediate at best in some cases and really terrible, especially look at the diet out there. You know, it's really not good. And these are things that people are accruing silently in their daily lives every day without a focus of renewing this and really optimizing this. Also, you know, I don't know how many clinicians are actually asking this on a daily basis to our patients. Like, how much are you doing in this space? So, not a good thing. But my focus recently has been on blood pressure management. A lot of the research has focused on how to improve hypertension. Hypertension is one of the easiest implemented and controlling risk factors. This is the biggest risk factor, highest morbidity and mortality of all of these risk factors that we know, and it's kind of an epidemic in our country. And I'll share some numbers of what's happening with the hypertension in young women. So again, I said this is the Cardiovascular Health Presidential Advisory, and in this advisory there are some critical time windows that the writing group that I had the fortunate I had the good fortune of being a part of, focused on. And focusing on these critical time windows where cardiovascular health can change, and also the patient is more likely to listen and implement and try to focus on are these windows that are windows of opportunity for us. Pregnancy is one of them, and middle age is one of them, which is two things that I have sort of focused on in terms of life course perspective. Really for us to say, this is a time for you to renew your focus on your future health. I don't need to preach to this audience on social determinants of health. Much of the work that I have actually learned from is from this institution. And I think sometimes in your life, like I mentioned, you come across some people that kind of change the way you're thinking. And Dr. Nasir and his team, I see Dr. Zaved is also in the audience. They have helped me think about the impact of social determinants of health and cardiovascular health a little bit deeper and better. We know that these are social factors, environmental factors, and sort of really healthcare accessibility factors that impact the kind of care patients get and the kind of health that they have. These are the root causes of inequity and the root causes of hypertension in our country. Not being able to afford medications, not having access to care, not being able to afford good food, you're in the neighborhoods that we live in. And I think one of the first steps in recognizing why cardiovascular health is not optimal is to really focus on the associations of social determinants of health and cardiovascular health. And this is one of my first works with Dr. Nasir's team that really actually made me think about, prior to that, I was focused on this acute problem with the adverse pregnancy outcomes and hypertension in women. And I think it allowed me to ask, well, why is it happening in women in this time frame? And what can we do about it? So I think the first thing is recognition. So this is the paper that we published that really looked at the strong and the stepwise association of social determinants of health, cardiovascular health. As you can see, 50% of pregnant women had the highest, with the highest social determinants of health burden by Kaiser Family Foundation SDOH questionnaire that was implemented in this data set, had also the worst cardiovascular health. And you can slice and dice this information with worsening quartiles of social determinants of health, and no matter where you look at this, the picture is that if you've got suboptimal social determinants of health, the likelihood of you having cardiovascular health not being good early in life is very, very high. And so this becomes it's an important point where it allows me as a clinician to say, well, maybe Garima, this should be the area you can focus on to try to make sure that this inequity could be solved at this critical time window when they are seeing you. And that has what prompted much of my research. So why women of reproductive age? Because that was my passion, and I sort of framed a study that got eventually funded by the American Heart Association. This is the focus of that study, that really looking at what's happening in our younger patients and our younger women before they come to us with a preeclamptic pregnancy. And so we really had to design something that was upstream, which allows us to assess cardiovascular health and social determinants of health in a younger population that is facing a lot of comorbidities. We know that there is a strong association. If women have suboptimal cardiovascular health during pregnancy, there's a very strong association of them having adverse outcomes, such as preeclampsia, that is well recognized. And then there's also an intergenerational transfer of that problem to the offspring. And so this is the parent study, which is the American Heart Association Safe Heart Study. This is the design and rationale of this. The design and rationale was to really focus on going to the communities around Baltimore and assessing cardiovascular health and social determinants of health in younger women who were not pregnant yet, looking at their cardiovascular disease burden, looking at their social determinants of health burden, and trying to connect them to resources that can help reduce these inequities. And this, happy to show you some of the slides that looked at this work. So this was designed to understand social determinants of health, cardiovascular health literacy in reproductive age women, also assess their psychological health, and then a phase 2 looking at a mixed method way of in-depth analysis of what their personal journey through this all was. And I won't go into details, but 300 community participants were recruited, 300 RGR. We leveraged a community sample as well as a sample from Research Goes Red. Primary outcome to look at health literacy, and secondary outcome was a change in health literacy. Did a lot of work in actually setting up community shops, going to community health fairs, going to colleges that are around Baltimore, and recruiting women into this. A lot of this work, and the shout out goes to my team, Dr. Faith Medlog, Dr. Yvonne Cometer-Mensar. They helped me actually become a better clinician by saying that you want to step outside your hospital and really go into communities around Baltimore and recruit. And so we were able to recruit in a massive scale, both phase 1 and phase 2. But I think for me, it helped me really become a more concrete scientist in this realm, really looking at community-led research and understanding how to create trust in our communities, how to build these trust, how to create partnerships with community-based organizations that help us advance the mission of cardiovascular health, how to create outreach, how to create authentic relationships, how to provide closed-loop feedbacks. When we designed the study, the community actually saw our questionnaires. They gave us input. They gave us input of how to make it better. We had a closed-loop communication where we were very much focused on trying to bring them back, bring the results back. And so we showed pretty much what we saw in our pregnancy questionnaire, which was there was a strong association and a stepwise association with adverse cardiovascular health and social determinants of health. As you can see, the left side is the community panel, and the right side is the RGR panel. The RGR panel are women with means, and they have insurance, and they are not from the community around Baltimore. They're a national representation. The community are younger women, 18 to 44 years of age, generally around Baltimore. And we showed pretty much the same thing, where their suboptimal cardiovascular health is associated with suboptimal or poor social determinants of health. But I will tell you, this data is actionable, because here is the power. There is a difference you can make, because these patients have risk factors. They don't have disease yet, or at least we don't know of it. And so there's a modifiable change that can be made in this. And then we put these patients through about 6 months of health education and health literacy to see if there was a change in health literacy. And as you can see, on the left side panel is before, and the right side panel is afterwards. The red is the community, and the blue lines are the RGR. And while there were big gaps and big differences in health literacy between our community group and the RGR group, with intensive education about life's essential aid, recognizing health behaviors, risk factors, we were able to close that gap in 6 months. But that work is not done yet. So, just because people have health literacy doesn't mean that there are actionable changes in health behaviors. And I think the bigger mountain to climb here is to design a study where there can be positive change in health behaviors, which I think is a bigger problem. And I think it's going to require a more systematic approach and a more wider lens on how people live and what can we do in order to actually make an impact in one or two health behaviors. Was making it at a very large scale would be very tough. So with that, I'm going to pause and pivot into the next part of the talk, is really learning the science and recognizing the gaps, and then going back to your health system and saying, well, what can I do at a system level in my clinic that is going to inform my patient better? And it is going to be a closed loop between all the clinicians, so that they're leaving their hospital clinic with a little bit more information, and we are caring for them a little bit better. We can talk a lot about cardiovascular health, but how are we going to actually make that actionable in our day-to-day clinics? Which is the lowest and the lowest hanging fruit, or the highest risk population that I can change right away? I know I can change it because I will use this information, and I'll create a care pathway that allows me to take care of these patients better at point of care. So we recognize that preeclampsia is a risk factor. We talked about this a lot. The scientific statement that I had an opportunity to be a part of is looking at the postpartum timeframe. Like I mentioned, most of my work is focused on pregnancy and heart disease risk. So the thought that came to our mind was, postpartum timeframe is a critical window, and the patients are still kind of engaged in our health system, sort of, and they're in contact with us. But how about retaining them for a longer period of time? Usually, women will seek care during delivery for 40 weeks, and when they have a hypertensive disorder of pregnancy, they're told, in the setting of a hypertensive disorder of pregnancy, you need to go follow up with your primary care doctor, or you need to go to see a cardiologist. As you can imagine, when somebody has had preeclampsia with severe features and they're volume overloaded, or their baby's in a NICU and they've had a preterm delivery at 34 weeks, and they're being discharged with 2 different medications, nifedipine and labetalol, and they're in pain, and they've had a C-section, and they're sleep deprived, if you're going to tell them, you need to go see your doctor in 2 weeks, it's never going to happen. and that's where the opportunity is lost. I mean, we can give them the information, but how can we make it actionable for them so that they actually see their doctors? The onus shouldn't be on the patient, because they're going to prioritize their baby, and they're going to prioritize rest and recovery. they may not really truly recognize how bad hypertension can be. And so you have to create models of care where you can get these patients and make the care easy for these patients, to hold them within the health system a little longer. And this is the model of postpartum cardiovascular clinic. We have a very flourishing clinic in our health system, and I will talk a little bit about how we model this. But we tend to retain patients with hypertension with severe features in our system for about 12 months. Along the course of that 12 months, we're helping our patients focus on health, rest, recovery, breastfeeding first, and provide them in the first 0 to 3 months with information that will help them be alert about their risk factors. At 3 to 6 months, we screen them for where they stand in cardiovascular health. And most of the numbers don't look very good at that time frame because they haven't really been implementing anything. But it is a way to reinforce what we want to reinforce about the things that we were talking about. So screening them for their cholesterol, screening them for their hemoglobin A1C, providing weight guidance, providing breastfeeding guidance, providing mental health guidance, providing guidance on planning future pregnancies, avoiding pregnancies that the patient may not succeed. This is the opportunity. So we do that around 3 to 6 months time frame, and then provide guidance on what we can do in terms of health behavior modification, see them again at 12 months. Many times patients appreciate the repeat messaging to them, and it finally does stick. And so I think that we have been fortunate to design something that helps us this. We're talking about the gaps in care. This is the gap in care. Many people will, fall through this gap. So closing this gap is important. So how did we do this? We did it both at the system level and the clinician level. So these are actually snapshots of what our EMR-based order system looks like. So there is a best practice advisory within the health system that if a patient has had a hypertensive disorder or pregnancy and they're being discharged at point of care from the OB floor, from the delivery L&D floor, there is a best practice advisory that fires in the chart that prompts the discharging OBGYN or maternal fetal medicine doctor to think about sending this patient to women's cardiology or cardio OB postpartum clinic because they have a reason to do so. It's not any different than we have the best practice advisories in patients with advanced heart failure or patients who are being discharged from the hospital. Would you consider cardiac rehabilitation? Or your patient has severe heart failure, would you consider mRNA? So it's a similar best practice advisory that fires, and you have to, before closing the chart, you actually have to settle it. That is an electronic order system that says refer to cardio OB, and it gives us exactly the reason why they're being referred. That goes into a queue, into our program coordinator's queue, and the onus is on us, not the patient, to call and schedule the appointment. And one of the metrics of success and the metrics of success of this program is the referral button to time the referral button to actually making sure the patient is called and a clinic appointment is made. And that almost always happens within the first 2 weeks of the patient being discharged. So we did design a study to see what happens when you do this. If you create a care pathway, does that make a difference? Do you actually make a difference in the patient's lives or in this referral pattern when you create an order set, when you create an order, and you make sure that the onus is not on the patient? So this was really done to evaluate the impact. And the paper that we recently published in JACC Advances was showing that if you actually create a care pathway, not only do you retain the patients for a longer period of time, but their screening actually improved. So we compared it to a historical cohort before the cardio OB pathway versus after cardio OB pathway, and we found that with this pathway and with this electronic-based referral system, which was prompting our clinicians to actually tell them what to do at 3 to 6 months, we were able to show a significant improvement in cardiovascular screening. We were able to show an improvement in lipid panel screening, LP(a) screening, ApoB screening, hemoglobin A1C screening, all of this in our young women, postpartum women, all these numbers were significant. So this is to kind of show that these kind of implementation care pathways are scalable, They are something that every health system can do. They don't necessarily need to always see a cardiologist. If you have a wide network of primary care doctors that are involved in this kind of care, you can involve them in this. But as long as you have a way to coordinate the care and everybody streamlined and doing the same thing, it makes a very big difference. And patients are actually getting some information in the early postpartum timeframe. I'm going to move on to key considerations in midlife. This has also been an area of focus recently because I recognize this just as postpartum and peripartum timeframe is an important, crucial time. The midlife is an important, crucial time as well, where the menopause transition, which includes both perimenopause and menopausal as well as postmenopausal time frame, actually ends up being a significant portion in somebody's life, and it can be a challenge. And that's why I think preventive care and women's focused care in this time frame is extremely important. So what's happening in this time frame? We know that estradiol, or active estrogen, is decreasing, FSH is increasing, and there's both chronological aging and ovarian aging at this time frame. So the cardiometabolic health metrics are actually worsening. There's a little bit of insulin resistance, patients are gaining visceral fat, there's elevated blood pressure, there's some amount of endothelial dysfunction, there is reduced energy expenditure because patients are exercising less during that time frame. Bone health is changing. A lot of times the first time patients actually present with ADHD and depression in midlife is during the menopausal transition because estrogen in the brain is deprived. We know that the lipid parameters are changing as well as up here. And sleep health is worsening. In fact, there was a recent survey that came out of the SWAN study that looked at sleep trajectories, and about 60% of women in midlife from that sample actually were sleeping poorly or sleeping less than the 7 to 9 hours that we recommend. And this is a paper that we published in your awesome journal with Dr. Zaved that's looking at recognizing these cardiovascular risk factors during the perimenopause and menopause timeframe, but throughout this transition. So you got to sort of have a system where you're expanding the lens for about a certain amount of time. So perimenopause is around 40, average age of perimenopause in the US is around 40, 41. And average age of menopause is about 50, 51. So perimenopause is actually happening a decade earlier than actual true menopause. And these changes are subclinical, they're subtle. And you'll notice in the labs, as you see in the women, there is a 15 to 20% increase in lipids. There's a 15 to 20% increase in all of their lipid panel and profile. And so looking at it through a longer lens and focusing on cardiovascular prevention is extremely important. But there are women from our certain segments of our society that are minoritized. And we know that social determinants of health, just as they impact cardiovascular health during pregnancy, they also impact cardiovascular health and adherence to your optimization strategies during the perimenopausal and menopausal timeframe. So more to come on that because there is some work that's pending. Hopefully the next time I come here, we'll have some more information on this. But recognizing that the same lens needs to be applied through the same focus across the transition is important. So how is cardiovascular health during menopause? Again, not very good. I showed you cardiovascular health overall in our population, then I showed you cardiovascular health in our peripartum, postpartum women, and this is cardiovascular health snapshot in the menopausal women as well. Just overall prevalence of cardiovascular risk factors. Green is good, red and yellow are bad. And so lots of red and yellow in our perimenopausal women, in fact, very little green. So it's an important strategy to sort of say, this is 20 years in somebody's life, 40 to 60 years of age, long time in somebody's life, and they're not getting the care that they need. The prevalence of obesity in our country is a problem. I think we recognize this as a big challenge. This is data from NHANES that's looking at the prevalence of obesity across sex and gender and age groups, and you can see women are not doing as well. In fact, women are worse than men because of some of this is explained by the menopausal changes in weight as well. But recently there was this Lancet Commission that redefined the way we look at obesity, where, traditionally obesity, we think it's body mass index, it's BMI, is really focused on your weight and your height. It's not a complete picture of assessing obesity in patients. It's not telling us about visceral fat. It's not telling us about fat that can be very causal in HFpEF or can give you increased atherogenesis. And so really recognizing that there are different changing metrics. BMI is not race agnostic. There are different race-based cutoffs. We know that in South Asians it's lower, but it was built as a metric of assessing your body weight and your body surface area, mostly in Caucasian men, which is not the rest of the population. And so the Lancet Commission actually redefined this. So in women, especially in our clinic, what are we doing? In addition to BMI, we're also assessing waist circumference. It's a one-time thing. You can do it. Waist circumference doesn't take, you don't have to put the patient through a DEXA scan, but you can actually do a waist circumference and you can do a waist to hip ratio. That, along with BMI, is a more accurate way of assessing in women. And it brings to forefront the problems that certain women may be having, where their overall BMI may not be that bad, but they have a lot of visceral fat, and their waist to circumference ratio is different. So recognition of this on how you can implement this. And I think this is not specific to women. I'm just showing you women numbers, but you can do this, you should do this for men as well. We've had some understanding about the cardio-kidney metabolic staging. Recently, a new paradigm shift in how we're talking about obesity, and obesity as a disorder, and obesity as a risk factor, and obesity as a problem longitudinally, and tying it with different cardiovascular risk factors. I think in terms of cardio-kidney staging, kind of giving a sense in your clinic, in your women, where they stand in your CKM staging is important, because a lot of this is usually stage 1 and stage 2 until they have subclinical disease. So getting into the practice of CKM, analyzing your CKM staging is important, because it's bringing to forefront some of these intertwined cardiovascular risk factors that have caused a lot of morbidity and are precursors of HFpEF. But the next 3 or 4 slides are going to focus on the problem and the good or bad, where you look at it, of these nutrient stimulant hormone therapies that we have for obesity management. Reports after reports of the massive prescriptions that are being filled. We know that this is important. This is here to stay. It does bring a significant clinical difference. They act in appetite regulation, changing glucose levels, improving cardiovascular health and kidney health. These are great tools for our patients. But how are we counseling our women that are on GLP-1s? This is important to recognize, because when you look at the uptake of GLP-1s, it's happening in the younger patients a lot, and it's happening a lot in midlife, right? Younger patients, because either it's because they want to look a different way, a certain way, they want to look healthy, or they're focusing on prevention. Midlife, the same thing. There is the same things that we've been doing in terms of diet and exercise don't actually work, because they're tied into decreasing cardiometabolic activity and your metabolic activity overall during that time frame. So how we counsel women that are on GLP-1 RAs actually matters. We know that there are unique cardiometabolic risks in women. We also know that because of certain cardiometabolic risks in younger women, they have unique risk factors, such as PCOS, which is a cardiometabolic disease. These are anovulatory cycles. Patients generally are overweight. They are mostly diabetic or pre-diabetic. And focusing on fertility and pregnancy considerations in this patient population is important. And also guiding our patients towards prevention of sarcopenia, because there's going to be, obviously, on these drugs, loss of fat, but there's also going to be loss of muscle mass, and that loss of muscle mass actually is associated to a higher mortality risk in women. And sarcopenic obesity is a problem where there is a decrease in muscle mass, but there's also a decrease in body mass. So focusing when we're talking about management of weight with these GLP-1s and cardiometabolic health, making sure that there's adequate weight training, there's resistance training, there's adequate protein intake, and making sure we're assessing sarcopenia and making sure our patients don't have that. One of the things that comes to mind in assessing and giving GLP-1s to our reproductive age women is to talk about the chances that there could be a pregnancy. And we've heard this about these Ozempic babies that happen. Patients are on GLP-1 receptor agonists, they lose weight, that anovulatory PCOS cycles become ovulatory cycles, and because they're on oral contraceptives, there's a decreased absorption of oral contraceptives, and they're not absorbing their oral contraceptives orally, and they're getting accidentally pregnant on GLP-1s, and then they're freaking out because these drugs are not approved in pregnancy, and there is this battle. What do I do? And then they have to abruptly stop their GLP-1s, obviously, and then decide whether or not they want to keep their baby. I cannot tell you how many patients we see that are desiring weight loss to optimize weight loss before pregnancy. One of the single biggest risk factors for preeclampsia and adverse outcomes is obesity, and optimization of weight. The reproductive endocrinologists are telling them, go lose a certain percentage of body weight before we actually can do egg retrieval or egg transfer, and then they're on GLP-1s. They're trying to rapidly lose weight and be optimized, but are we providing them with the right tools to kind of avoid a pregnancy that they don't want? And so really focusing on, when you are counseling your patients who are reproductive age, thinking about better contraceptive care and changing that contraception to a transdermal contraception, or a long-term reversible contraception like an IUD is extremely important in these patients so that they can avoid unwanted pregnancies. And this is unpublished work, hopefully published soon. We actually did a small meta-analysis looking at all of the GLP-1 exposures. And how bad is it if you get exposed? And why are we freaking out so much? Is it really that bad? And so we didn't find a whole lot of studies, to be honest with you, because there's been a lot, about 4 studies, about 36,000 patients, but they're not as bad as we think. Even if you're exposed to this pre-pregnancy or during pregnancy, you stop it, at least it's not being associated with any adverse maternal outcomes or fetal outcomes just yet. So we'll see if this actually lands in a journal, but we're happy to provide some information that may necessarily not make our patients freak out. So the last few slides are focused on menopausal care transition. We talked a little bit about health equity and specialization of care and community-based care and primary care integration. But menopause is having its moment in time, actually, and much needed moment in time, and trying to recognize that this is a important time phase, and we really need to, our health systems really need to be equipped to provide effective care for women. And it should be equity-based and equity-focused as well, so that we're not leaving behind those people who actually cannot get the kind of care that we need. So what do we do in our health system? So we were able to create a care pathway, just like in postpartum cardiovascular health, a care pathway in a menopause transition clinic. And these are just some flyers that are clinician-facing that we have been able to activate and send through MyChart on certain patients that we see in our clinic, so that we know we can communicate with their primary doctor saying, hey, we've got a clinic, please send us your patients if you're thinking about hormone replacement therapy. In the middle are a bunch of people from our group that are very, very excited to take care of these patients. But this is a patient and a clinician-facing thing that we've started to circulate in MyChart, that's focusing on what the problem is, who are the people that you can seek out care to, and what kind of assessments are we doing. And so on the right side are these assessments. If you send us these patients, we will do a reproductive history, we'll look at their reproductive contraceptive care, we'll look at where they are in their menopausal stage, and then we'll do their cardiovascular risk assessment. So how do we do the cardiovascular risk assessment? This is a wonderful paper that is published by Lily Dashmalchi, who's the head of our menopause program. If you're high risk group, for example, you've had a stroke or a TIA or significant subclinical atherosclerosis, CAC score of 300 or higher, or peripheral artery disease, you fall into a category where hormone replacement therapy is not indicated currently. And we can have a separate debate on HRT. This is not a talk on HRT. We can talk about why Women's Health Initiative was not the best trial and how we outblow the findings of the trial. But in reality, currently, we don't provide hormones to these patients who have established high-risk cardiovascular disease or have a significant ASCVD risk score. In the other two categories, which is intermediate risk and low risk categories, actually it is very much provided, at least in our healthcare system, and having a shared decision making with our patients and assessing their subclinical risk is what we do. So we'll usually stage their CKM staging, we'll consider doing a CAC score if we think that they are in the intermediate category and we want to make some decisions about where they stand in their health, whether or not we want to put them on a statin therapy. And then in some cases, and where patients have symptoms, we may even do a stress test to see what their exercise capacity is. And many times, based on that, we'll say, you are okay and you should be able to get HRT. But this is what's starting to happen. I think building a menopause program has been a lot more challenging than building a cardio-OB program, because the source of referral from a cardio-OB program is actually the OBGYNs. They're pregnant, they want you to see them, they're antenatal, they can't escape you. And they're going to be in your system for 40 weeks, so there you go, you got an opportunity. This is a different opportunity, it's posing certain different challenges for the health system, because patients seek care different places. Their primary care doctor doesn't necessarily have to belong to your system. There's somebody somewhere else. Their GYN is somewhere else. They're getting their urogyn care somewhere else. They're getting no exercise care, whatever. Like, it's all over the place. So it's been a little bit more challenging. That's why I think having a team or identifying a team of clinicians within the health system where the patients can make it easier for the patients to navigate. Our nurse navigator actually helps with this a lot. When a patient comes to see us with cardiovascular risk stratification, she'll say, "Hey, by the way, after this, we did a sleep study, so here's a sleep medicine referral, and here's a behavioral referral for your depression symptoms, and you could go see the sexual health specialist if you're having low libido," and it's all kind of integrated in the system, where the onus, again, doesn't fall on the patient and they feel like the doctors are talking to each other or the care providers are talking to each other. But identifying a network of people within your health system that are specializing in these kind of cares is extremely important. And then connecting your patient with that. So not only is there a menopause care pathway on what type of risk stratification we should be doing, but then when you risk stratify them and you identify the problem, where you should be referring to them has to be tied in with that care pathway as well. So this is a work in progress. Hopefully, I'll have some more data on showing how the care pathway improves, adherence to screening protocols in menopause in the next 2-3 years. But proud of what we've been able to achieve so far in a pretty clunky, large health system. And lastly, I talked a lot about cardiovascular gaps. I talked about the awareness gaps. I talked about the inequities. I talked about the opportunities. I talked about integrating social determinants of health and cardiovascular care. We were able to discuss the challenges of bridging health system to community work and integrating communities into the health system and how we can do it. But the work is not done. It's a process. I think you create a pathway. It's 1.0, and then some things don't work, and then you come back and you do a 2.0 version of it and a 3.0 version for it. So hopefully it'll be something I can refine over a period of time. But I leave you with this. I think there is a lot to do in the space, and it cannot be done through one lens. You have to broaden your lens, and you have to focus not just on clinical care, but raising awareness, optimizing prevention, supporting research that aligns with your clinical work so that you can advance the mission of your research and your mission of your care. At least that's what I've learned through this. Work is not done unless you actually engage communities around your health system and make them a part of the solution and don't think that they're a part of a problem, but they're actually a part of the solution. That's how your message gets broader and more people buy into it. And then you have to, you have to study, and you have to write, and you have to publish, but you also have to advocate. You have to be there for your patients. You have to be there for people who don't have the voices. You have to legislate. There are certain things that unfortunately or fortunately, the way you look at it, are going to create more inequities in women's care. And I think we have to sort of, as clinicians, empower our patients to be more informed, to make better decisions for themselves. I'll stop there. I'm happy to take questions.
Yes. Garima, what a wonderful talk.
Really, the most impressive thing is the key impact is taking, of course, finding the questions, doing the research, but taking it to the clinic and to the community. A big message for all of us. So, I have one question and I'll ask. And for hormone replacement therapy, of course, the highest risk if you have a ACVD 7.5 or 10%. What's your protocol? Usually, if you do a calcium score and it's 0, do you downgrade them and say it should be okay?
That's a great question. So it's a very good question. So this is the problem with hormone replacement therapy, right? Like, it wasn't designed. It's not designed. The trials that we have did not inform what we need to do in patients with this high risk patients, right? So Dr. Nasir's question is actually very on point because we deal with this every day. There's a patient with SCAD, a spontaneous coronary artery dissection. He's had a dissection for some unknown reason during hormonal changes. They don't actually have coronary atherosclerosis. They don't have coronary atherosclerosis. You do a calcium score in them, and the calcium score is going to be 0. But they have had disease. So it's a gray zone. What do you do in this patient? You don't have an answer for them. We didn't do the trials that way, so we can't inform them any better. In those patients who's Dr. Nasir's question is, you got these intermediate people, or you've got a high risk people with their prevent score is 7.5 or higher based on the score. So they have risk factors for sure. Then you assess whether or not they have subclinical risk. And if your calcium score is 0, you should be able to give them hormone replacement therapy, and you should be able to monitor them throughout that process. So you can say there's a significant risk factor burden, but I am not seeing significant disease. So this patient is in a different risk category, and maybe you can de-risk them a little bit. Much of your work on de-risking patients, and maybe allowing them to get HRT with closer surveillance. Follow them up every 6 months or a year. Check their blood pressure, give them the tools, check their lipids. If symptoms arise, proving that they're not cardiac is important. So a little bit of more shared decision-making and diligence part in that space. I will tell you personally, there are patients who are 50, 51, 52, menopause occurred 2 or 3 years ago, who are asking for hormone replacement therapy. CAC score is not 0, but it's not 300. Gray zone, but we treat them because they have subclinical disease, but they don't have overt disease. You got to prove that they don't have overt disease. And that patient population, I've tried to put them on a treadmill and say, hey, I'm going to push you. Can you show me where your functional capacity is? How much you can do? Let me see what happens to your blood pressure when you exercise. Let me see what happens to what your wall motion looks like. And if it's a great Bruce protocol, patient did well, 10 minutes plus, no exercise issues, yes, you can get them therapy. So I think the one size doesn't fit all in the situation, and I think it requires us to do a little bit more deeper.
Thank you for an excellent talk. I really enjoyed it. My question is, I'd like you to talk about the social determinants of health and how to treat the cardiovascular risk factors early on to try and prevent some of these hypertensive disorders of pregnancy, or at least try and prevent them preeclampsia so the severity isn't as great.
Yeah.
My question is, you mentioned going into the colleges. Do you think that's soon enough? Perhaps even we need to go earlier, like into high schools, to teach people how to eat healthy, exercise, all of these other things to prevent the risk factors and therefore possibly prevent all of these complicated pregnancies.
I couldn't agree more, because I mean, you're right. When as I learned through this process, I'm like, this is still not primordial prevention, because I need to go even a decade earlier. The answer is yes. The answer is yes. It's actually high school education, high school food, school food, kind of things that we need to target in our younger patient population is important. And things are kind of changing in terms of, how early we should be recognizing these risk factors. It's a challenge because we live in the adult world. We have to partner with pediatricians. We have to partner with preventive pediatricians or preventive primary care doctors that are seeing these patients, and that those partnerships are a challenge to do many times, because our entire focus is on cardiovascular disease, morbidity, and mortality, and we just haven't had a broader, bigger focus. I appreciate that question, because it's very true. By the time an 18-year-old is seeing us in the community and we're screening them for cardiovascular risk factors, they've already lived 18 years in a certain way. They're already eating in a certain way. Their exercise is in a certain way. They're approaching life in a certain way. And I think that as much as it's early enough, it's not earlier. It's not the earliest we can get them.
And the second part of that question is, I know you talked about your cardio OB program and how you get all the referrals prior, the prenatal visits. The question is, the cardiologists and their role in that, and, in the people who have the cardiovascular risk factors, is the aspirin being given, and how do you coordinate all of that? Because it seems like you can also have a huge impact
Yes.
in the prenatal visits or even prior to pregnancy.
Yes.
I mean, how soon are you seeing these patients in your cardio OB clinic?
That's a great question. I didn't show you the data. We're actually seeing them as soon as they're pregnant. So one of the things that I showed you, mostly the postpartum data, because it's, but in the antenatal time frame, if patients have suboptimal cardiovascular health, which is 2 or more risk factors, or even chronic hypertension, our health system has started to send those patients to us. So we're actually doing an integrated care pathway for those people that we think that are at high risk of having a preeclamptic pregnancy. And so as soon as they're pregnant, the OBs will say, okay, go see these people here in cardiology and get your cardiovascular risk assessment. So when we see them, we will do the whole assessment and we'll say, yes, you've got this risk factor, your Mediterranean type of diet, this is your exercise, get your blood pressure, monitor your home blood pressure, keep your logs. These are the signs and symptoms of preeclampsia. So all we're doing is reinforcing what the OBs are also doing. We're just reinforcing them. The patient's hearing two same messages from both the ears from 2 different people. And then the ones with chronic hypertension will actually see them once antenatally when they get pregnant. We'll see them once in their 2nd trimester and once early in their 3rd trimester. And if they're doing okay, then we'll say, they're doing okay. Aspirin allocation is also stressed from both sides. So whether it's 81 or 162, depending on how, the OB's desire, will say, yes, please go ahead and adhere to that. And so we have started to do that a lot. And we actually are seeing more and more and more patients come to us because the message is resonating. And it is also creating a streamline of patients within the cardiovascular community or cardiovascular health system that, usually we don't see. But it's helping patients. I don't have data to show you if that kind of integrated care pathway actually makes the patient more nervous or actually really improves health outcomes. I think we'll have to design a study, and maybe I'm getting I'm getting a nice idea in my head from you. So thank you.
Last question.
All right, thank you so much. Very enlightening talk, shedding light on an important topic. My question is, how do we foster the collaboration with gynecological clinics and OB clinics? Because I feel like as a woman, you spend more time in the waiting rooms of those clinics compared to PCP or cardiologist. And how can our PREVENT score be part of the template, similar to how their, the menopause and contraception, scores are in our templates? How do we increase the awareness by really leveraging these opportunities of the interaction with the gynecologist, preconception, OB during conception to raise awareness about cardiovascular health?
Yeah, first thing you got to really find a very passionate group of people within OB. OBs are extremely busy. They're busy. I mean, we're busy, but they're like crazy busy. Like, you have to give them a lot of grace. And so they're going to focus on the sickest of the sickest, worst patient. I think there are two things you can do. You saw the My Chart pamphlets. It's easy to create that for anything. And say, give it to the OB practice and say, can you put this in your clinic? And if you see a high-risk patient with cardiovascular morbidities, can you push this through their My Chart so that the patient has some information on that site? That's one thing which is very actionable. Patient will get it through their My Chart, or they'll get it at their visit, or in their office when they're sitting there, there's a flyer for the patient to actually act on. The second thing is actually finding a very passionate collaborator from OB. And nothing is built in a day, right? Like anything worth building is built over a long period of time with a lot of iterations. You got to start somewhere, and you say, let's put this screening plan in place. If you've got 2 or more cardiovascular comorbidities and you're pregnant, would you consider sending this patient to us? And having a sort of a building that sort of a collaboration is helpful, but you have to build it with people who are truly involved and have the bandwidth to do it. System-wide, leadership can play a very big role in this. I will tell you that this is successful in our health system because the OBs actually wanted to do it. It was driven by the OB service line. They were like, we need to really do this because